So today I'm going to talk a little bit about the scope of the problem of non-adherence to medications and how critical that is to us as a society as well as to you individually as patients. We'll review some of the determinants, if you will, of why non-adherence occurs, and then explore some of the opportunities to improve care through better adherence. And I'll focus this predominantly on patients at risk for thrombosis. Now, just to give you a bit of the lay of the land here, if we think about our current healthcare landscape, we recognize that about 2/3 of office visits generate a prescription medication. The difficulty for us, though, is what actually happens to those prescriptions. And what you can see on the right-hand side is that if we start to look at some of the behaviors with respect to those prescriptions, about 1/3 of people may take the prescription less than often. Many people may delay filling it, so there are gaps in their care and their treatment. About 1 out of 5 people may stop a prescription sooner than is warranted. Nearly 1 out of 5 may never fill that prescription. And finally, many people may in fact take smaller doses than what has been prescribed by their clinician, maybe cutting that pill in half and thinking that less is more. So we clearly have an issue. We have multiple prescriptions prescribed. We have gaps in how our patients are taking those. And unfortunately, this amounts to poor outcomes for our patients and maybe adverse events. Now let's think again about this in terms of prescriptions overall in the U.S. It's estimated that half of the 1.8 billion prescriptions that are dispensed in the United States are not taken correctly. This is critical specifically for patients at risk for thrombosis because the medications are very specific. They have very specific thresholds that need to be achieved in order to improve outcomes and reduce thrombosis, but also avoid bleeding. It's estimated that the overall cost of poor adherence, if you measure it in otherwise unavoidable medical expenses, is about $290 billion per year. And that's about 13% of the U.S. healthcare expenditure. We know we're struggling with healthcare in the United States, and some have suggested that medical non-adherence is America's other drug problem. And then until we can address ways to improve our patients taking medications appropriately, we will continue to have these dramatic costs to our society and our healthcare system. So this isn't just an issue within the United States. The World Health Organization has identified medical non-adherence as a #1 priority worldwide. Their statement states that increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any other specific improvement in medical treatments. So clearly this is a major issue. Now let's step back and talk a little bit about definitions. I've used the term adherence, and that is definitionally the extent to which a person's behavior corresponds with agreed recommendations from a healthcare provider. Some of you may have heard the word compliance, but we now use the term adherence. Persistence is another term that you may hear used, and this is the duration of a treatment. So, for example, the length of time that a patient may fill their prescription. Now, here's really, if you will, the reality of healthcare. Again, we've heard a lot about science and the evidence base that exists to deal with thrombosis. We have many therapies that can improve outcomes. The difficulty becomes the reality in which we all exist. Whether we're a healthcare provider and maybe we don't give the right dose to a patient or escalate dose or tend to give lower doses because we're concerned about a side effect. And that's modified a lot by the physician characteristics on this side. The other side is the patient's role and patient adherence. Is a therapy initiated? Is it adhered to? Does the patient persist in that prescription? This is modified often by the other diseases or comorbidities that a patient may have, as well as some of the demographics. Their age, for example, may make it more difficult for them to manage some of these medications. Their behavioral characteristics. We know that people who are depressed and not feeling empowered in managing their disease are less likely to take their medications. We also know that the more complicated a medication regimen is, the less likely people are able to take it. That has to do with not only the number of pills, but how many times a day someone may need to take it. And finally, there are environmental factors. How difficult is it to get a medication, for example? What does that do in the context of your everyday activities? So the difficulty is that in an ideal world, we would all practice evidence-based medicine. A prescription of a medication known to improve your outcomes would be prescribed. A patient would be able to adhere to that 100%, and we would optimize patient outcomes. But the difficulty becomes that the world intervenes and often makes it difficult for us as patients to adhere to that. Now, when we talk about thrombosis, it's very complicated. It's nice to have the talk before me to really give a lay of the land of the various therapies. But each therapy has both its pros and cons. If we think about warfarin, for example, there are many limitations, and patient adherence is really central to our ability to provide optimal care using warfarin. As many of you as patients know, warfarin isn't just about taking the pill. It's about managing your diet. It's about getting the monitoring consistently. It's about working with your healthcare provider to ensure that you're in an optimal INR range so that you can really get the best benefit of that therapy. But we recognize that there's sometimes unpredictable responses in given individuals. It has what we call a narrow therapeutic window. So we need to maintain that INR in a very strict range so that we don't have thrombosis in a low end or hemorrhage and bleeding in the high end. It does require a lot of monitoring. So this is an investment from the patient's perspective, and we need to ensure that all these issues are taken into account. So as patients, I urge all of you to make sure that you ask your provider about a therapy. What will it entail? Try to understand that as best as you can to ensure that you can take it as is being recommended. Now, when we think about warfarin, and most of the data come from the management of atrial fibrillation, this is looking at about 600 patients with a first ischemic stroke who had known atrial fibrillation at that time and were classified as high risk for a stroke, and who otherwise had no reasons why they shouldn't be on warfarin. And what you can see from the pie chart is even though these individuals met every criteria for taking warfarin, they were otherwise ideal for taking the medication and at high risk, about 2/3 were not prescribed warfarin. That's a healthcare provider adherence issue. The flip side of that is that in those that did take the medication, only 10% of people actually had their INR at a target range. And fully 30% were at a subtherapeutic range. So they were not getting the benefit of that medication for whatever reason, perhaps non-adherence was contributing to that. When we look further into stroke prevention, again in atrial fibrillation, and we try to explore what the reasons for Coumadin non-adherence are, again, this is multifactorial. Sometimes physician judgment played into it, such that a physician thought that perhaps the patient was at low risk for stroke and didn't receive a medication. But from a patient's side, often patients prefer not to take something like warfarin. And again, it's important to consider your preference as a patient for a given therapy, as well as fully understand what the implications are if you're not taking that therapy, particularly when it comes to thrombosis. Another quarter or so were concerned about bleeding risk. So you can see that the constellation of adherence or lack thereof can have important issues, and there can be multiple reasons why individuals may not adhere. Now let's look at a variety of determinants of non-adherence. And we recognize that this is really a multi-level problem, and certainly this does not solely rest on the patient. In fact, very significant barriers to adherence exist within our healthcare system and exist at the level of the provider. First, I'll go through some of the issues within the healthcare delivery system. Now, I'm not sure we had to do a scientific study to figure this out, that if things cost more, you may be less likely to use them. In this particular study, when co-pays for medications increased, and when the patient was asked to share the cost more of a medication, they were less likely to adhere. This just shows that over the last several years, you can see the number and increase in co-pays over time. These are old data, but the numbers have continued such that co-pays are taking much more out of an individual's budget and impacting their ability to have therapies that their providers may prescribe. If we think about what may impact non-adherence from the patient level, there are a variety of factors. So obviously, when a provider prescribes a medication, the ability for a patient to adhere to that regimen depends on many, many, many factors. It depends on whether the provider has communicated in a way that the patient understands. Not only that they understand what the medicine is, but why it's important and what the consequences of non-adherence are. So communication barriers are a big one. From the patient perspective, non-English speaking is a big one. And it's important, if you are not a native English speaker, to ensure that you either have translation or someone who can assist you in understanding. Sometimes, if we look at literacy, and I'm not talking necessarily about just reading and writing, I'm talking about health literacy and the ability to understand complex medical terms, that low health literacy can be a barrier to adherence. We know also that substance abuse and mental illness can contribute. We know that socioeconomic factors, whether they be inadequate health insurance, unemployment, poverty, or concerns about costs, can drive much of the decision and create barriers. And we also know that patient motivation, whether it's because they have a poor understanding of their disease or illness, are not empowered to really manage their disease, or if there's a lack of perceived need for that given therapy, that motivation or lack thereof can again impact non-adherence. Remember, though, that this occurs in an environment in which, as healthcare providers, we may have limited time with our patients. Medication regimens are often quite complex. The average patient in Medicare now has, on average, 8 medications. So the medication for thrombosis may just be one of many. There's need for monitoring We have economic pressures. We have multiple medicines that may interact with each other, and all of these things conspire to make adherence quite difficult for the average patient. Now, I want to go back to health literacy and just highlight this because this is really critical, and it's critical that everyone understands that the medical language that we speak is certainly not English, and it does require a certain level of understanding. And health literacy is defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services in order to make appropriate healthcare decisions. Now, what does that mean? So if we look at this, the current guidelines actually set health literacy at a 4th grade reading level. We know that patients who are not literate with respect to their health may be less likely to understand either oral or written information and instructions, are less likely to act upon procedures or understand directions, and far less likely to be able to navigate the healthcare system. So organizations like this that promote patient advocacy, promote education at an appropriate patient level and an appropriate level of health literacy are essential in helping patients ultimately achieve their outcomes. We also know that people who have lower health literacy are more likely to get their healthcare services in public venues and overall incur higher costs. And we know, unfortunately, that poor health status is disproportionate in individuals with low health literacy. Now let's talk a little bit about providers and how they may impact non-adherence. So as providers, we need to do the best we can do to help inform you of a medication, the risks, the benefits, the alternatives, and counsel you through that in such a way that we can come up with a plan that will best fit in a patient-centered way to have you achieve the kinds of outcomes, meaning reducing thrombosis in this instance, or preventing disease and disability. The counseling skills, the involvement of a patient in that decision-making care plan are critical, but recall that as providers, we're often under significant time constraints, and we need to work together with patients to come up with the best plan. So from my perspective, an informed patient coming into the practice, understanding as much as they can about their disease, armed with questions they may have for me, can help me be as efficient as possible in the limited time that I may have. We also know that team approaches in clinics that have multiple support for a patient tend to do better at allowing patients to adhere to their therapies. Now, when it comes to trying to improve medication adherence, I think intuitively we appreciate that it probably takes multiple different kinds of approaches and interventions to help patients adhere to often complex medical regimens. Right now, the trials that have been performed have only improved drug adherence on the order of 4 to maybe 10, 11%. Most of these have focused on technologies, reminders to improve adherence. But we haven't really found that best single strategy. But I think to take us back to the patients on an individual level, the best strategy is to have a conversation with your healthcare provider and ensure that all your questions have been answered about a medication and that to the best of your ability you understand the recommended plan, and if you can't follow that plan, work with your provider to sort out what alternatives might be. We also try to help patients, for example, understand that they have other networks that can help support them. So we know that social support, patient advocacy groups are quite helpful, and individuals engaged with either high levels of social support or patient advocacy groups tend to do better in managing their disease. This is a social support questionnaire from Duke. that can really help identify those individuals who may need more social support or those who have adequate social support. We also know that follow-up and staying linked in with the healthcare system is important, and we know that provider follow-up and continuity of care are critical in improving long-term adherence. In this particular study that didn't look at thrombosis but looked at statin use, that most patients did better if they had continuity. If they had a gap in their coverage or gap in their treatment, that they were much less likely to ultimately adhere to their therapy. So again, staying connected with the healthcare system is critical. Now, there are a variety of different ways that we've tried to measure patient adherence. So often it's helpful for patients to have a reported grid of how often they're taking their medication, if they might skip doses. Sometimes we can have patients bring in pill bottles just to ensure that the medications are actually being used appropriately. And often in many medical systems and in pharmacy systems, patients receive reminders. So many of you may be reminded by your pharmacy that your refill is due, and this is quite helpful to ensure adherence. Now, this is a scale called the Modified Moriski Scale. And what this does is really help understand whether you as a patient might be at risk for not taking your medicines. The questions are really simple, but I think all of us can kind of look at these, and I'll go through them and think whether or not you're at risk for not taking your medicines. I think number one is, do you ever forget to take your medicine? Now, I know if any of my patients really answer no to that, they're probably lying. So I think it's very hard to remember all your medicines all the time. Are you careless at times about your medicines? When you feel better, do you sometimes stop taking medicines? Remember that many of these therapies, particularly for thrombosis, may be lifelong and are not associated necessarily with how you feel. You may feel wonderful, but still require these therapies for prevention. The flip side is sometimes if you feel worse when you take your medicine, do you stop taking it? So again, how do you do that? The answer to both of those should be that you don't stop taking medication. Do you know the long-term benefit of taking your medication as told to you by your doctor or pharmacist? This is critical. We know that patients that truly understand why they're taking medications and what the long-term benefits are much more likely to continue that therapy. And then lastly, sometimes do you forget to refill your prescription medication on time? So we have questions about motivation in the middle column, questions about knowledge on the right, and from this we can get a sense of how motivated and knowledgeable our patients are. Again, speaking to that triad of education, knowledge, as well as motivation working together for adherence. Now, this is an important program that is adapted from the Partnership for Clear Health Communication at the National Patient Safety Foundation. And I think if there's one thing that you want to take away from my talk, it's this, if you're a patient. There are 3 essential questions that patients should ask their doctors. They are, what is my main problem? What do I need to do? Why is it important for me to do this? 3 questions. What you should expect from your healthcare provider is that you are provided with a clear diagnosis that you understand, that you're provided with a treatment plan, again, that you understand and can act on. And you should know what can happen if you do not follow those plans. We know that patients that apply these 3 questions and receive these answers from their healthcare provider before they leave actually are much more likely to take their medications, but more importantly, are much less likely to be hospitalized over the next year and actually have lower mortality, lower death rates than patients who don't get this information from their office visit. There are a lot of factors for that, but clearly a motivated, empowered patient that gets this information will do better in general. So in summary, I'd like to say that non-adherence, as I told you, is highly prevalent, unfortunately far too prevalent, and has substantial negative outcomes of health for individuals as well as our health nationally. We believe that improvements in adherence have the potential to dramatically improve outcomes for our population as a whole, and specifically in patients with chronic conditions, including thrombosis. And we believe that a really multifaceted approach, engaging the healthcare system, providers, and most importantly, patients, has the opportunity to be most effective. So I want to thank you for your attention, and I'm happy to take questions.
We'll take one question from the audience. Please come up to the microphone.
A very quick question or comment. My name is Alan Call, and I guess the issue with persistence, adherence, and compliance has been ongoing for many, many years. And one possible hope might be the movement towards patient-centered medical homes and more effective transitions in care. I think the latest figure I just read from a report that came out, I believe it was an IOM report that was pre-release copy, 66% of medication errors, and unfortunately it didn't break it down into whether it was antithrombotic or otherwise, occurred during transitions in care, is going to or from nursing homes, from hospitals, or from other types, or from home environments without appropriate follow-up. And the team approach and the patient-centered medical home maybe will offer a little light in addition to some of the points you've brought out.
Yeah, thank you. So I think that a move to patient-centered care that really envelops patients through inpatient, outpatient, really makes those transitions, which are the most dangerous, as easy and as straightforward as possible, will likely benefit. Thank you.